सर गुड इवनिंग सर, जॉइनिंग सर। बस शेयर कर रहा हूँ सर स्क्रीन। हाँ सर बस। हाँ सर शेयर किया सर स्क्रीन जस्ट। यस। यस।
स्वास्तिक गुड इवनिंग। गौरंग शाह सर ज्वाइन हुए हैं शायद।
यस हाँ सर ज्वाइन हुए सर।
हाँ हाँ। लेट्स वेट फॉर 5 मिनट्स। आई थिंक गीते सर ज्वाइन हो जाए ना, देन वी कैन स्टार्ट।
यस सर।
गीते सर ज्वाइन होते हैं तो वी कैन
यस
स्टार्ट।
सर ओके सर।
यू वांट टू शो द स्लाइड्स टू द स्टूडेंट्स?
यस आई विल स्टार्ट सर।
ओके।
ओके सर, आई जस्ट गेट द टाइमर ऑन सर also. So we will start the OSCE session. There will be 7 questions. The first one is here. Your time starts now.
Who's answering, Swastik? They are there.
Yes sir. Dr. Ajinkya sir is answering, and then
Okay.
two students from onco-surgical unit are also there. Dr. Chintan
Sure.
and Devraj. So I will start the timer. Fifteen seconds left. Next question coming up. 1 minute left. Fifteen seconds. Next question. One minute left. Fifteen seconds. Next question coming up. One minute left. Fifteen seconds. Next question coming up. One minute over. Fifteen seconds left. Next question. One minute over. Fifteen seconds left. This is the last question. 1
Swastik,
minute.
this is the last question, no? Swastik?
Yes, sir. Last question, sir.
Okay, I think Gite sir has joined and Mahendra Pal sir has also joined. Good evening, sir.
Yes, sir.
Good evening, Nagin bhai.
Good
Yeah,
evening.
good evening. I'm also there for some time.
Yeah, sir is also there. We are blessed to have him, even from Egypt.
From top of pyramid, sir.
Current?
From
30
the
seconds
top
left.
of pyramid.
Yeah. No, we are going to have our meeting in another 40-45 minutes with some urologist in Egypt.
Wow,
Okay,
that's
okay.
interesting.
Yeah. So I'll be there till that time.
10 seconds left. Sir, these are the 7 questions for this OSCE session, sir.
Fine. Some of the questions, like, they have not been framed properly. But anyway, we can discuss. This can come as a viva or either on the table also. Fine. Who is answering today?
Sir, Ajinkya and I think Devraj.
Good. Again, the old people. Ajinkya, welcome.
Yeah, good evening, sir. Thank you, sir.
So, like sir said, these slides have got few questions, but anytime we will be adding some more questions so that there's a good discussion. So, let us start now.
सर इसमें कोई ऑन्कोलॉजी केसेस हैं क्या?
है
One case is there.
अच्छा.
महेंद्र भाई को ऐसे
No, but
महेंद्र भाई को ऐसे ही नहीं परेशान करेंगे.
no. But Mahendra,
Yes, sir.
sometimes like this, in this case also you can ask for the
Yeah,
Correct.
I have
onco
only
cases, na?
one question. One question by saying this thing: how will you differentiate between the cystitis because of radiation and this spot diagnosis? Yeah, other than history.
Very good. So that's a very interesting question. Let's start with that. Bolo Ajinkya.
So the first image shown is the severe mucosal redness and hemorrhage, and the second image is showing punctate hemorrhages in the mucosa.
Hmm.
Could be because of cystitis.
So how many glomerulations you should see?
4 to 5, sir.
At how many spots? You have to answer the question
Exactly.
completely. Yeah.
So the exact criteria I'm not remembering right.
Is there any criteria for interstitial cystitis? Okay. What Dr. Mahendra Pal sir asked, how can you differentiate
between radiation cystitis and the interstitial cystitis? Other than history, definitely you will have history. Other than, suppose the patient comes in the casualty with unreliable history, then how will you differentiate? I think symptoms are almost same in both the cases.
No, I guess.
Have you ever seen done claudication for the RT or maybe normal post RT bladder? You have ever scoped?
Once, sir. Right.
So it is actually mucosa is pale. This thing post radiation. It is not pink like this until it is infected or something, but not. It is pale, and you will not find such capillaries in the mucosa with the pink background. Okay.
Yes, sir.
Yeah.
I think that is a very good practical point. So you must remember, it's a very good point. Okay. Now identify the condition. So you said cystitis. Any
Cystitis.
other differential diagnosis?
And one more thing to add, in this you can get angry mucosa, and in post RT bladder there is a patchy, no, pale mucosa, then patchy this thing congestion of the mucosa, then this is the patchy picture, not the generalized angry mucosa. These 2 points.
Okay.
Yeah.
So very good. This is generalized if you can see that.
Yeah.
Yeah. So criteria you said that we'll be seeing several patches of this and at least few glomerations per patch should be there. Okay. What are the indications for Botox therapy in this condition? So you tell everything about Botox, how it works, what you will do, how you will instill it, how it works.
Botox works on the principle of it blocks the acetylcholinesterase release, the and prevents the further muscle constructions of the bladder, and uh, it is prepared like it is in the powder form. We need to prepare it. You can use either NS or with the distilled water. It should not shake. It should be prepared. Should not shake while preparing it. Slight slow mixing of it, and you have to dilute it into 20 to 30 ml. And then with the cystoscopy and with the Botox needle, we have to instill Botox at intervals of 1 centimeter on either of the side by sparing the trigonal area.
In which way?
Yes, sir.
In the pyramidal way, na? Means like 5, then you'll
Didn't
go for
yes.
4, 3, 2, and 1, like that. So if Tanvi is around, Tanvi can just tell us. Tanvi,
Yes, sir.
you've
So
done
Botox
few.
prevents the phosphorylation of the snare proteins and hence prevents the release of the acetylcholine from the vesicles.
the dosage of this Botox therapy is usually 150 to 200 international units. There are three indications that is written, as you all have discussed. There are three indications for the Botox therapy. First of all, the patient should be refractory to the treatment for more than a year, to all sorts of treatment. Secondly, the patient's urine culture sensitivity should be negative. And thirdly, the urodynamic studies should not have a contractile detrusor or decreased detrusor function, because Botox paralyzes the bladder and that can cause retention later. So these are the three indications. The installation of Botox is done with the cystoscopic needle, as Sir said, in the pyramidal fashion, which means that at around 2 centimeter intervals, you have to start from above the near the trigone, and you keep like going, in a line and further away, so that all the quadrants and everything is uh, getting some injection. The way the injection is done is basically in the submucosa. You insert the needle, aspirate once to confirm it is not in a blood vessel, and then you have to inject the medicine. When you inject it, you have to make sure that a submucosal bleb is formed. So this is the procedure for Botox. I'm sorry. I'm sorry. So this is how the injection is inserted. Sorry for that disturbance.
Madam
Yeah.
has so nicely said, see, this is the way to answer. Huh? This is super. Very well, Madam has said. So this is the way you have to tell everything in detail.
So that is how Botox injection is done. And one more thing I wanted to say, the effect of Botox lies for around 10 to 11 months. Sometimes this effect, the injection has to be repeated.
So Ajinkya, how
Yes, sir.
often you can inject?
How, interval, sir?
One is the interval and how many times you can do it.
So 2 times maximum.
Good. What is the interval? How much interval?
6 to 7 months interval, sir.
A minimum of 6 to 7 months you like to wait,
Yes.
or 3 months. Dr. Gite, can you just put some light on that?
2, maximum 3 times it is given. It is a temporary treatment because interstitial cystitis doesn't have any curative treatment. That is one. Another is how someone clinically identify the interstitial cystitis. Usually, a young female is age-wise, young females are more prone than the male. Male interstitial cystitis is rare. Dysuria, urgency, frequency, and suprapubic pain is a classical 4 features of the interstitial cystitis. There should be glomerations or Hanner's ulcers, cystoscopy, and pain with urgency or suprapubic pain with urgency is one of the diagnostic criteria. There are 4 to 5 C's which predisposes the interstitial cystitis like carbonated beverages, caffeine, chocolate, citrus, and high dose of vitamin C. There are multiple names for this disease like chronic pain, pelvic pain, then bladder PBS, that is painful bladder syndrome or bladder pain syndrome. Usually on cystometry, the compliance is reduced. Overall, the capacity of the bladder in radiation cystitis or interstitial cystitis is slowly in chronic phases it will get reduced. And multiple options like there are intravesical therapies, then behavioral therapies, then injection therapies. So this is a majority a theoretical topic. Chronic topic doesn't have chronic disease doesn't have as classical curative treatment. That's what from my side.
Yeah, but in one of the lecture they had said that the Hunter's glomeruli are there and they actually do the resection of those glomeruli also. You know?
Agreed, sir. There are multiple trials and error type of treatments like intravesical heparin, intravesical xylocaine, then distension of the bladder for multiple times. Various type of treatment is described in the book, and people were using multiple combination of the drug intravesically. That's what.
Yeah, and another thing is even though if it is not under acute recusal, still patient goes into retention, and it is not necessary that every time it may be a small capacity bladder. It may be a normal capacity bladder also. And one of the urologists has not yet, presented that paper, but he has shown that by not doing the actually not an augmentation, but just by putting a patch of intestine on the bladder, he has cured almost 15 to 16 patients in last 10 years. That is what, we have attended. That paper is probably going to be published or whatever it is. So, and not augmentation. It is not and not an augmentation cystoplasty. Fine. Okay. Next, Swastik.
This question to be taken up by onco president,
Yes.
Dr. Chintan sir.
Someone is asking NIDDK criteria. There is NIDDK criteria. There is European Society for Study of Interstitial Cystitis. This is another criteria. Then clinical criteria for diagnosing the interstitial cystitis. You all should know all 2 to 3 types of criteria.
Yeah, Mahendra Bhai, please take over.
Yes, sir.
Hello, good evening, sir.
Yeah.
Yeah.
Okay.
Sir,
Yeah.
sir, Devraj here, sir.
Yeah, tell
Yeah.
Devraj.
Sir, this is the specimen in the radical prostatectomy, sir.
How do you know that?
Sir, because of the this architecture of the specimen, sir.
Describe.
Sir, it's looking specimen like the prostate, and here the inferior surface we can see this thing, sir.
Devraj, when sir has already asked you, describe means you should go in full detail. Don't
Yes,
wait
sir.
for the next question.
Yes, sir. Yes, sir. Sir, this is the urethra, sir.
Okay, fine. You should learn how to describe the specimen. That this is a uh, some triangular shape with apex downwards, and at the top of the specimen there is some tubular structure going upward bilaterally. Okay, and the lateral view, the apex is on the left side, and these structure are going from the most probably base. And the third picture, the same way with having some tissue bilateral, most probably the lymph nodes.
Lymph node.
So
Yes, sir.
the specimen will be the structure which are tubularized structure. There may be the vast difference on the cycle, and the apex
Yes.
most likely this is a specimen of the radical prostatectomy with LND.
Yes, sir. Yes, sir.
This is the way I think last class I told how to describe the specimen. Anyway, okay. Indication of this surgery.
Sir, indication of the this surgery is the intermediate risk.
Only intermediate risk.
Sir, intermediate risk and also high risk also, sir. But in low risk, sir, EPLND usually we will not do, sir. That PLND.
So you cannot say it's a localized prostatic
Yeah,
cancer,
yes, sir, localized
organ
organ
confined prostatic
yes,
cancer. No,
yes,
whatever the risk factor is there. Okay, whether high risk, intermediate risk, favorable, unfavorable.
yes, sir.
Okay. Okay. What is the indication of LND and its boundary?
Sir, boundary the superiorly this bifurcation of the common iliac bifurcation, and laterally genitofemoral nerve, inferiorly deep circumflex femoral vein, and deeper is the obturator nerve, sir.
Okay. What are the type of LND can be done in
Sir, either
cancer?
this standard or extended, sir. Usually,
only two. Only two.
Sir, only two I know.
Okay. Do you know about the super extended?
No, sir, I'm not aware.
Okay. Okay. You
So
should
you
know.
must also describe it in detail, na? When it is done routine, when it is extended, when it is super extended. You have to give full answers, Devraj.
Yes, sir. Yes. So, sir, usually in the extended, intermediate risk, we will do the extended, and low risk, we will do the standard, sir.
आप पास नहीं हो पाओगे ऐसे में. Standard is not recommended. Standard. It is always extended. Actually, extended is the standard one now.
Okay, sir.
Okay.
Yes, sir.
Yeah. अगर करना भी है तो आपको minimum extended करना ही करना है. This is the recommendation nowadays. If LND has to be done, it should be only extended, not the standard. Okay.
Yes, sir.
Okay. So suppose that if you are doing the surgery, whatever method, robotic, open on the lab, and do you send note for the frozen, and will it affect the management?
No, sir.
Why?
Sir, because we already going for the extended pelvic lymph node, even if positive, sir, that adjuvant treatment we will further plan. But extent of the surgery, sir, we will not same
No,
given the
this is not the way answer. The way of answer should be because the LND has a prognostic value in this case, diagnostic and prognostic.
Yes.
In the past, it was thought that if node is positive, abandon the procedure and give hormone therapy.
Yes,
Okay?
sir. Yes.
Nowadays,
Yes, sir.
anyway, you have to go hormone therapy, but you have to do complete extended LND. Okay?
Yes, sir. Yes, yes, sir.
Okay, fine. Can you just give me one trial name in localized prostatic cancer? The practice changing trial, the only name. Tell me the name of the trial of localized prostatic cancer.
No, sir, I don't.
which proved that active surveillance and radiation therapy and surgery or are almost equal in localized prostatic cancer. नाम पता है?
No, sir.
या ये आपको आना ही चाहिए.
Yes, sir.
This is a very important trial. Okay, tell me the indication of active surveillance in prostatic cancer and what is the strategies. Do you know about it?
Sir, if patient is the asymptomatic and life expectancy of the patient is the more than 10 years, then people the strategy of the active surveillance to the don't overtreat the patient, sir, and we will regularly follow up patient with the this thing clinical examination PSA.
Tell.
Yeah, and if there is a patient either developing the symptoms or abnormality in the this thing, then we will plan. Then we will, according to that, we stratify the patient and manage.
So first you stratify based on clinical symptoms or based by the disease profile?
Sir, both, sir.
Both. What is more important?
Sir, disease profile is the more.
हाँ तो उसमें यह डालना. It is a low risk, very low risk, and
Yes,
selected patients of favorable intermediate risk.
Yes,
Extended
sir.
indication.
Yes, sir.
Okay.
Yes, sir.
On those cases, you can offer active surveillance. Okay.
Yes, sir.
And you should also know about the follow-up protocol when you are offering a patient active surveillance. Okay.
Yes,
now,
sir. Yes.
Now tell me, this procedure was done.
Yes.
And this is a pathology report.
Yes, sir. PT3A-N1, sir.
Okay. So how will you treat?
Sir, we will offer the patient to the adjuvant treatment, sir. Adjuvant EBRT plus BRT boost plus androgen deprivation therapy long term for up to 2 years, sir.
2 years. Why not 3 years? He has having a extra prostatic extension and metastatic pelvic nodes also.
Sir, N1 then, sir, 3 years, sir. 3 years.
Okay, if no N1, then 2 years.
Sir, if then 2 year, either more than 2 high risk like
basically it is, yeah. So it is a long term ADT. 2 year, 3 year is not being defined exactly. It's a long term ADT. When it's a short term ADT, it is 6 months, of course.
Yes, sir. Yes.
Yeah. And okay. So
sir, N0 is ADT indicated, like if there is N0.
No, N0. If there is no N0, only you have to only give a RT. Adjuvant RT. Role of abiraterone prednisolone. There are trials coming on in that adjuvant therapy, but at present this is not recommended. Giving abiraterone and other than trial. Only if very high risk patient and multiple this there's a study positive result, but at present is it not routinely given. Abira with ADT. Okay. What else, Gaurang Shah? What anything else can be asked in just for this slide?
In this, I don't think so, because on the specimen, only those many questions will be asked. Unless and until you can add something like, if the patient has got metastasis in such case, then what you will do, but we have covered almost everything.
Yeah. P3A N1 is okay. Okay. Yeah. So how will you decide in P3A clinical P3A or B decide the treatment option, surgical and the radiation? How will you decide what factor you will take to decide the treatment option?
Is clinically P3 only, na sir? Clinically P3, sir, we will see this thing ISUP grade also, sir. Along with that, if grade is the more than 4 along with the more than T3, then 2 high risk, sir. Then we will offer this thing long-term EDT. If only 1 high risk, then short-term EDT, sir.
No, not this. I'm saying primary, not after therapy. I'm saying the clinical. That means patient is treatment naive.
Yes, sir.
And he's having
Okay.
T3B without
Yeah.
node. Then
Yes,
how
sir.
to decide between the RT and the surgery? You
Sir,
cannot say I'm a surgeon. I will not offer. I will
yes,
not
sir. Yes, sir. Yes,
offer
sir.
him
Yes.
RT.
Yes, sir. So we will explain, sir, the advantage and disadvantage of the both to the patient of surgery and radiation, because surgery is the single sitting procedure, sir, usually. So, surgery is the single sitting procedure. Patient is the young, then radiation we can reserve for the future treatment, sir. And radiation effect advantage is the to organ preservation, and ultimately maybe there is the possibility to patient ongoing after surgery, even after the surgery he will require for the radiation. So both aspect I have to explain the patient and let him decide.
Okay, fine. And also one thing, Gleason grade. If the higher
Yes,
the
sir.
grade,
Yes, sir.
there are more chances of
Yes, sir.
biochemical recurrence. Okay,
Yeah.
and in those patients, better to avoid surgery, because anyway they are going to have biochemical recurrence after the definite therapy.
Yes, sir.
And
Yes,
maybe
sir.
bladder neck involvement and T4 disease. Okay.
Yes. Yes.
Yeah, that is fine, sir. Gaurang Shah, sir.
Yeah, only one question. When you in such case, in this case, when you
Yes.
will offer him radiation therapy, after how much time?
Sir, after 6 weeks
Mm-hmm.
after 6 weeks of completion of surgery, sir.
What is current recommendations? 2 trials. नाम बताओ 2 trial के.
Sir, trials I'm not aware about the trials. Have to read.
आने चाहिए.
Yes,
Yeah,
sir.
it is
Yes.
radicals and rave. 2 trials हैं, radical and rave trial. One says adjuvant RT, one says salvage RT. Okay.
Yes. Yeah.
And the review article about the both trials says that whether do you give adjuvant RT or the salvage RT, survival is almost same.
Okay.
Okay.
Yes, sir.
Yeah.
But sir,
But Mahendra, after how many, after the surgery, how many? What I have understood is minimum 6 months you should wait,
Yeah,
and then
sir.
offer radiation therapy.
Yeah, generally, what happened till the every healing process is complete. 3 month earliest can be 3 months, but 6 months is also. Otherwise, suppose that some margins are positive and serum PSA is 0 for 1 year, 2 year. Even when it is rising, then we can give also RT. So that becomes salvage RT or adjuvant. We have to give at that every given time frame. So in our hospital also, it is generally given on 6th month. But if there's extensive EPE and something like this, such everything, and serum PSA second setting it is marginally raised, so maybe 3 months also has been given.
Yeah, but normally we like to wait till patient becomes
Yeah,
continent, because
it's continent,
otherwise it
then
may
healing
have.
process. Yes, right.
Yeah,
Right.
correct. Fine. I
Okay.
think we can go ahead. Correct.
Yeah. Next.
The given picture is angle tip 0.035 inch guide wire. The types it can be classified depending upon the tip. It will be angle tip, J tip, straight tip. Depending upon its the coating, it will be a guide wire or glide wire. Depending upon its the inner material could be either made up of stainless steel or nitinol. Uses it can be used to gain access in endourological surgery like URS, can be used for degestenting to tract dilatation in PCNL.
So this is angled glide wire. You should specifically say that in difficult intubation, very lateral orifice, or some reimplantation or something like that. In those kind of situations, maybe you need an angled glide wire where you are not able to reach. Or also in cases of difficult anatomy or congenital abnormalities like retrocaval ureter or ectopic ureter or ureterocele or some things like that. Those are the cases where normal guide wire we may not, and we may choose angled glide wire.
Okay.
Should I go for next question?
Yeah, I think Swastik, you can go next.
This one for onco residency.
Dr. Chintan is also there in onco resident.
Yes,
He
sir.
can unmute.
Let Dr. Chintan answer these questions.
I
Mahendra,
think he has. I think he has left the chat. I will tell him to join again. Till then, Ajinkya can continue. I will just.
Ma'am, we have Dr. Devraj also. If you can
Yeah,
take.
I
Oh,
will. I will tell. I will tell. Till then, you can continue with Dr. Ajinkya.
So the given drug is mitomycin. It is an alkylating agent. It inhibits the DNA synthesis. The indication, it could be used as a post-URBT as order to prevent seedlings of the, or it can be used also as intravesical chemotherapy. Contraindication should not be used in case of gross hematuria, there is bladder perforation. It is a class of chemotherapy. It is an intravesical chemotherapy. Uh, Steps of installation. Uh, the ideal period is said to be within 24 hours, but it is better if given within 6 hours post URBT. We should see if there is no, there should not be any perforation, should not be active bleeding or hematuria. The mitomycin, a dose of 40 milligram, is diluted in 50 ml of NS, and then instilled into the bladder. And the holding period is around of 1 hour is kept, and then uh, it is emptied again. Uh, this is the for the post URPD. In case we wanted to give it in as a heterocycle chemotherapy in case of BCG failure or BCG intolerant patient, the dose is 40 milligram. The regimen is for once per week for 6 weeks after 1 month of PRBT, and then later on after 3 months we can give once month for 10 months.
You said everything except for non-invasive. That you should have said, no? Preferably in non-invasive tumors. If it's an obviously invasive tumor, you would. What is the purpose of using
Yes,
it?
non-muscle invasive.
What are the various ways to it's a routine and high wake. Two things. The routine, that means post URBT.
Yes, sir. And it can be used as intravesical chemotherapy.
And high wake.
High wake, yes.
Okay. And about the contraindication, the other one is the allergy to the mitomycin C, history of allergy to the mitomycin C. Okay. So,
yes.
Yeah. I don't think so. The question for the mitomycin C, that is okay. The installation should be under gravity. Also should be there.
Yes, sir. Not.
Yeah. Okay.
40-year-old diabetic female post PCNL and post OD should develop hypertension and fever. So my initial differential diagnosis, the first would be having sepsis, which is resulting into hypertension and fever. Could be sepsis plus hemorrhage, which is resulting into hypertension and fever. Here I like to investigate this patient. First of all, I like to see the color of the urine, and in case the nephrostomy tube is kept upon, what is the color, the content of the nephrostomy tube. Then I'll also like to, apart from routine blood investigation, I like to get the CBC, the urine routine microscopy, the urine culture sensitivity. I'll also like to
You have to do blood culture also, no? Urine culture, blood culture.
Yes.
And also, patient is in hypotension. So will you wait for CBC?
I was waiting for him to say, because hypotension is very, very. You have to read the OSCE questions very well.
Yes,
See,
sir.
patient is in hypotension. Now, how will you
Yes.
manage? Madam has given you all the answer.
Step up the antibiotic which is already the patient is already
That's
on.
all.
Uh,
Hypotension.
Fluid resuscitation, sir.
If you keep on giving fluid and BP is not coming up, what will happen?
Fluid overload, sir.
Then your see, this is not the way. In exam, you have to say how will you manage a proper urosepsis patient. You'll take a good IV line. You'll see that you'll step up the IV antibiotics. You'll send all the investigations. You'll see to make a strict input-output chart. You'll monitor the BP. If the BP is not coming out, you will take intensivist and physician opinion. You may have to start ionostropes. If you just keep on giving fluid, what will happen? Patient will go into fluid overload, pulmonary edema. Next day morning,
Yes.
you would have given 3 liters and no urine has come. This is not the way. You have to think patient will go into surge and sepsis and septic shock.
Yes.
So anyway, after you do all this, what Hiren sir has said, everything, and you shift to ICU, then what will you do? As you said, now the patient has been given inotropes, he's been on IV fluid, everything. We are resuscitating him, and his fever is still there. BP is so coming up little bit. Now, as you said, your investigations. What will you do? And now, how will you, after the basic resuscitation? Then what is your next step?
Madam has given you one hint. You only said that there could be even hemorrhage, right? But you have not asked
Yes,
for
sir.
that investigation.
देखो, if you have not think by a broad way, this is a first post-operative day and post-PCNL patient and diabetic. Okay. So what are the possibilities that should come in your mind?
And
So
also
one
staghorn.
and
So
staghorn.
multiple punctures.
Yes.
ठीक है.
Yes.
So it may be infection, it may be bleeding, it may be extravasation, compression.
You never asked for ultrasound only. That's what I was
So
waiting to see.
your first aim is, okay, where is the problem? So how will you search that? For infection, for bleeding,
Bleeding.
and
Ultrasound.
for local condition. If a patient is clamped, not clamped, what if it is unclamped, what is coming through the PCN? How is the color of the urine periothly?
Yes, sir.
So if you think like that, answer will one by one, you will going to answer every question. If you think only by fever, inspection, and diabetes, that means you restrict your thinking to the infection.
See, what you do routinely now, we want you to tell that only. You will
Exactly.
go to the you go to take round and you will inform sir now that sir BP has not come up. Next step, what will you do? What all you will think? You will think whether bleeding is there or not. First post-operative day, infection. So you will send all the cultures. What all investigations you will do? How you will take the big bore IV line? Then you will start IV antibiotics. Just routinely what you are doing. You have to say that only.
Yes, sir.
Don't get nervous. It's okay if you make mistakes here. Keep smiling and keep presenting. That's it.
Yes, sir.
Sir, good evening.
So should I move to the next question?
Good evening. Good evening.
So Ajinkya, this is the case.
Yes,
So
sir.
you answer one by one. First, I will recheck the BP, confirm it that there is hypotension, try to give 1 point of fluid, upgrade the antibiotic, We'll send the blood culture, CBC, serum creatinine. Go for sonography bedside, one chest X-ray. Then check the patient. What is draining? If I will I open it and what is the content? If it is continuously draining blood or not. Check the color of the peritoneal catheter. Then, as per the finding of various report, CBC, various report, I will further change my treatment if required. Keep one ICU bed ready. Inform the intensivist if it is chest problem. If it is bleeding, clamp the SPC, give the blood. If it is continuously bleeding, then go for angiography. Small one it is there, angioembolization. So ये पूरा सीक्वेंस दिमाग में बिठा के लेना है.
Correct. Also, you have to
Yes,
say
sir.
ICU, shift to ICU, put central line,
If
monitor.
same patient in thinking that same patient is in your OPD, in your ward, what you will do routinely, what your boss asks you to do routinely, वो सीक्वेंस से बताते जाना है, गलत नहीं होगा 99%.
Plus, you have to be
Yes, sir.
scientific. Na? You'll see the CVP, you'll adjust the fluid accordingly. You'll just not give fluid like that. You keep on
Yes,
giving fluid, BP is not coming up, what will happen?
Exactly. Sir, anything more, sir? Pankaj, sir?
I missed the initial case details, so maybe you continue. I'll join in the next case.
Okay, sir. So, anything more, Hiren, sir?
I think good, sir, we can proceed. So they should read about management of hypotension, SIRS, and septic shock. That is very important.
Systemic inflammatory response syndrome, SRS,
Yes.
oblique sepsis management. You should
Yes.
write in 10 to 12 lines. That sequence you should mug up and be ready with the answer.
Very important. All urological cases, especially this kind of PCNL, anytime matrix stone, patient can go into hypotension immediately. You have to understand all these things and how to manage sepsis very well. Without that, there is no point. In entire life, it is going to come in use.
Agreed. So, should we go for next?
Yes, sir.
Uh, 72-year female with fever and pain, diabetic. Specimen looks like a calculi.
Now
That's-
read the history again. They have given you some hints.
Could be a papilla, slough papilla.
Yeah, they have
That's
given
where
you some
you
hints.
make the mistake. You zoom out that picture, see carefully. What is the configuration? What may be the probable consistency of that thing given in that picture? Shape.
Smooth margins. The shape is of the
So it is either a very soft stone
stone or a
renal papilla. Left out renal or necrosed renal papilla. इससे अलावा और कुछ हो सकता है?
From the history, you should say papilla first, and then maybe
Yes,
second differential diagnosis as stone because of the shape.
Exactly.
But very clearly, they are giving you indication.
Correct, sir.
So management part.
So what are the probable causes for having this condition?
Sir, papillary of course. One is diabetic.
Okay, diabetes. Next one.
Obstructive uropathy, post-transplant
देखो ये बड़ा इम्पोर्टेंट क्वेश्चन है। ये थ्योरी में भी आ सकता है, प्रोबेबली आरजीपी या फिर आईवीपी का पिक्चर या फिर सीटी का पिक्चर भी अगर किसी के पास है तो रख सकते। तो कहीं ना कहीं डिस्कशन में रेनल इन्फेक्शन आ गया कि आएगा, क्योंकि एनी डायबिटिक पेशेंट स्टोन वो भी अगर केस है तो इसमें भी वो आ सकता है। तो ये थोड़ा सा टिप ऑफ टंग पे रहना जरूरी है। जैसा कि प्रोलॉन्ग्ड यूज ऑफ नॉन स्टेरॉयडल एंटी इन्फ्लेमेटरी ड्रग्स, दैट इज वन ऑफ द प्रीडिस्पोजिंग फैक्टर। Then sickle cell disease is one of the predisposing factor. Diabetes is one of the predisposing factor. Then infection, various type of infection, and in combination, multiple things. When in combination is probably the predisposing factors for renal papillary necrosis. How it presents, usually it will present like a ureteric colic, it will present like infection, it will present like passing of tissue bits in the urine, probably have a history of diabetes. Then you should remember the synonym postcard. Postcard meant
Postcards.
pyelonephritis, obstructive
Pardon.
uropathy, sickle cell disease, tuberculosis, chronic liver disease, analgesic or alcoholic,
Okay.
renal transplant, post-renal transplant, diabetes mellitus, and systemic vasculitis.
Sickle cell.
So this is a synonym है। और treatment तो it is depend upon the presentation, treatment of presentation and treatment of the cause. So if it is presenting like ureteric colic, then ultrasound system of hydronephrosis, obstructive uropathy, you have to deobstruct that situation with doing the stenting, or if it is not stent is not draining, then PCN. Starting if it is associated with infection, then the culture and culture specific antibiotic. If it is associated with diabetes, कंट्रोल ऑफ अनकंट्रोल डायबिटीज, जो भी पीरियड ये अगर चीजें तुम्हारे दिमाग में बैठ गई, ये प्रीडिस्पोजिंग फैक्टर्स है, तो उसका एक ट्रीटमेंट बोल दिया तो एग्जामिनर हैप्पी हो जाता।
Yes.
So anything more anyone want to add? अगर कोई है तो बताओ। ये जो कॉमन पॉइंट्स है ना, स्टोन हो, ट्यूबरकुलोसिस, या फिर 3 to 4 5 मैलिग्नेंसीज, ये चीजें एकदम डीएनबी में, अगर डीएनबी दे रहे हो तो तुमको बिल्कुल मगप रहना चाहिए, तो उसमें कोई कंफ्यूजन नहीं रहना चाहिए। So discuss the management. Is the last question that you just read that probably that is RGP picture.
The RGP image shows a guide wire and the pyelogram. You can see some filling defect in the collecting system, and
बाबा इतना ऑब्वियस है, एक्स्ट्रावर्जेशन नहीं बोले तो फिर कैसे चलेगा?
extravagation. Yes, sir.
So there is one guide wire which is going towards the middle calyx, multiple filling defect in all the calyxes. There is extravasation.
Extravasation of the line.
Contrast along the wire, contrast is seen in the ureter. ये फटाफट चीजें बोलना है। There is no any obvious filling defect in the ureter, ये अगर है तो है। ये सीक्वेंस अगर ध्यान में रखा ना तो इजी हो जाता है।
Hello.
Sir.
I want to ask only one question to him. Routinely, will you like to do RGP? Number one. And if you want to do, which condition you will do RGP? Suppose if you are suspecting patient has got emphysematous pyelonephritis, or he has got severe pyelonephritis and there is an obstruction, you want to stenting. Will you like to do RGP? Number one. And even if you want to do RGP, in which condition? Ajinkya, can you just answer?
No idea. Yes.
See, normally, these are the patients, they are very sick, and we don't want to give a longer anesthesia, or we don't want that dissemination of the infection. So, if in such condition, we
Not to
just
be.
do a stenting. Only thing is whenever you are in a
Yes.
doubt, whether you are not sure, you know, and you are suspecting leakage, extravasation, and you want to do PCN. So these are the conditions. Then you'll do RGP. For example, you have put a guide wire, but you are not confident. You don't know whether it has gone, into the
Yes.
false passage, and that is the time you will like to do RGP. Second thing is, if there is a too much of perinephric collection, and you are not sure whether there is a continuation leakage or not, extravasation, or you want to do PCN. So these are the three conditions where you like to. Otherwise, in routinely, I feel that just do DJ stenting and come out.
Sir mentioned
Okay.
APN. What is the classification?
So there are various classifications used. One is the Van classification, which divides into dry and wet type. Then there is Young and Thiessen's classification. Then Algezawi, Pfister, and Langston classification, and Michelet classification. These are the classifications.
Good.
Should we go for next?
I will put the next question.
If no, we should go for next.
So the right side two images, you can see a hooded penis with the ventral opening, very proximal opening of the meatus. It is the proximal shaft hypospadias. So surgery done. It would be a single stage. I cannot identify on this what type of surgery is done.
The question was to be the surgical management of the condition in the brief. Second one is provided.
Surgical management.
They are asking you what types of surgical management will you do. So what are the options that you have to tell?
Sir, considering the proximal hypospadias, I'd like to first, under anesthesia, I'd like to assess the this chordae. If the chordaes are less than 30,
Beta,
30
first you say principles of management. Hypospadias, no? Simple thing. That's where you will score your marks. So you tell the principles of management, what all you would like to keep in your mind. It's a proximal hypospadias. What will be the condition of the urethral plate? What all you will think. Then you say what you do.
So I'd like to assess the urethral plate, the meatus, then the chordae on clinical examination. The principle is based on the we need to get to correct the chordae correction, then the neourethra development, and then the orthoplasty.
Now you tell procedures, no? Tell procedures, two stage, single stage.
Yes, a single stage, if less than 30 degree of temperature and can be managed with dorsal plication, you can go ahead with single stage procedures like you can use TIP here, as Snodgrass, or you can use only preputial flap. If more than 30 degree, or if we have to divide the urethral plate, we might have to go ahead with stage procedure. If the doing it in single stage, After transaction of urethral plate, we can use ASOFA, or if doing in two-stage, we can use bias flap or bypass grafts, two-stage surgery.
Whenever you got a case of hypospadias, so first of all, you should rule out this is a primary hypospadias. So there is no any surgery done prior. That is one. That is one thing. Another thing, while examining the patient, uh, what are the things to be noted in your local examination is the first you start from the prepucial hood. So it is a thick prepucial hood or a thin prepucial hood. Number two, glans width. So it is a small glans or adequate width. So it should be at least 1.9 centimeter in adult. Then meatus. So proposed meatus and hypospadic meatus condition. So in the glans area, that meatal area is developed and the urethral plate in the meatal area is granular or flat. Then hypospadic meatus, is it a stenotic and not stenotic and site. Then urethral plate is what is the width of the urethral plate and what is the configuration of urethral plate, that is superficial or in depth, that is granular. Then the surrounding skin, it is a pliable, not pliable, associated with multiple skin tags. If it is operated, then there are maybe multiple skin tags or scars. Then width of the penis, the age of the patient, and then the scrotum, both the testes are in size, at normal size and size, and if it, then next is a planning. So what is the planning? What are the possibilities in this patient? Whenever there is a hypospadic meatus, proximally, more proximal, more chances of CORD. Because then another important thing is the condition of spongiosum. So the bifurcation of the spongiosum is at what place? The development of the spongiosum is up to what place? Then if it is reaching to the glans or not. And as per all these factors, we have to plan the things. It is a single stage or multiple stage. So if it is a single stage, then whatever you told already, if it is ideal urethral plate and ideal candidate for snodgrass, then it is snodgrass. Then dorsal prepucial only flap. Then if it is a single stage, then decade. Then if you want to single stage, then koyanagi. These are the multiple options for single stage. If you want two stage already operated, then two stage with the skin as a buyer and two stage associated with the prepucial flap, or two stage if it is operated, there is no prepuce, then it can be done with the BMG, that is BRCA 1 and BRCA 2. So ये पूरा fix है. It is like a mathematics. Then complication, immediate complication, delayed complication. Again, QARDI, 85% of the QARDI is due to the skin. After deglowing, I will reassess by doing the Gite's test. If it is a QARDI more than 30 degree, then go for the correction of the QARDI. Then QARDI is by the lengthening or by the shortening. So by shortening means plication. Lengthening means multiple ventral incisions or excision and graft.
Yes.
This is the QARDI treatment. Then is it associated with any torsion? This also clinically you have to see. That one point I have missed. There is associated torsion or not. Then immediate complication. Immediately on the day, there are chances of bleeding. Then hematoma. Then blackening of the glands. Then in perioperative period, it may be an infection, dehiscence, wound infection. then in the 8-9 post-operative day or some delayed post-operative phase, it will be multiple fistula, single fistula, then complete dehiscence, and then
meatal stenosis, neourethral stricture,
meatal stenosis. These are the long-term complications. Then again, long-term complications
BXO.
are complete DXS, BXO, stenosis, stricture. Okay. Hypospadias is like this.
Yes.
Are you aware of Professor Asopa?
Yeah, he.
Not
If you don't know him, that means बड़ा difficult काम है क्योंकि India, hypospadias, India and Asopa.
I wanted him to say, sir. And
Yes,
recently we lost Professor.
Exactly.
So you must know that he was from India, from Agra, and very well known all over the world for his technique. And recently we have lost Professor. So proudly he was part of Urology Society of India.
Exactly, sir. So anything more questions? Something anybody want to add? अगर ऐसा कुछ है तो नहीं तो फिर नेक्स्ट कुछ है तो नेक्स्ट क्वेश्चन की तरफ जाते.
Sir, this was the last question, sir.
Okay, then मेरे ख्याल से okay.
Sir, one question, sir. Sir, ideally, this diameter, planning to use it as a without what should be the diameter?
Ideal urethral plate.
Yes, sir. In case we are using it at single stage, 5 mm, 8 mm.
Minimum it is 8 mm. Minimum.
Okay.
If it is more than 8 mm, it's okay.
I think it is over now.
हाँ, आप
sir, I think slides are over.
कर दो वहां से. Sir, about OSCEs, please ask.
You can say.
Otherwise,
you can say care of.
चलो हमको आपके बहाने देखने को मिल गया.
So last question, sir, is in Egypt. Which urological disease is common in Egypt in the river Nile?
Very important question.
So we end here.
In the chat, somebody answered schistosomiasis.
Yeah, very good.
Dr. Ankur has answered.
Yeah.
Okay, sir. Enjoy Egypt on our behalf.
Okay. Good night. Good night to all.
Thank you for joining us. Students are blessed.
Thank you, sir.
Thank you. Thank you, Gite sir, Pankaj sir, Mahendra bhai.
Thank you. Thank you, Gite, Pankaj, Hiren.
Gaurang Shah sir. Good night, sir.
Good night, sir. Good night.
Good night.
Thank you, Tanvi.
Swasti sir. Swasti sir, kindly end the session.
Yes, I will do.